Perfect. Well, thank you, Finn, and for TBMAC for having me here to present the work in a nice, friendly, constructive environment, as you said. Um, so basically, my plan today is to present some methods and results from the work that we've done on evaluating the potential health impact of new TB vaccines in low and middle income countries, particularly vaccines that meet the WHO preferred product characteristics. And so this work was a huge team effort. And so the co-authors from the study are listed here and will be at the end as well. So just acknowledgements to all of them for everything that they've done. And this work is an amalgamation of everyone's progress. Oops. So to start off, TB is a very serious global health issue, as we all know, which causes significant morbidity and mortality. It was a leading cause of death in 2019 and for the past couple of years from a single infectious agent, and the burden is the highest in low and middle income countries. There are some promising vaccine candidates in late-stage trials, as well as different policy recommendations for current vaccines like BCG. And introducing these vaccines will be key to reaching elimination goals. But as we know, development of TB vaccines is expensive and long, and there are a lack of market incentives from organizations and companies to invest in vaccine development. And so what we wanted to do with our work, and particularly with the publication results that I'll talk about today, was to estimate the potential health impact in LMICs of vaccines meeting the technical specifications of the WHO preferred product characteristics for new vaccines. We wanted to do this to be able to support the case for quicker development and adoption and implementation of vaccines in country. So we're looking at 135 LMICs as per the 2019 World Bank income groupings, and we were looking at the impact in terms of cases, deaths averted between 2028 and 2050. And so I'll start by going into a bit more detail about the natural history model structure that we assumed when we were simulating the epidemic. So one of the things that we've done in this work was incorporate some of the more novel discoveries in tuberculosis natural history into our vaccine model structure. So as you can see, we have everyone who starts in uninfected naive, and when they become infected, they can progress to an infection fast state, where fast progression can occur within 2 years, and otherwise continuing on to infection slow with progression not occurring within 2 years, but those individuals are still at risk of progressing to disease. While they are still within that compartment. They're also at risk of reinfection as well. But we've incorporated self-clearance, so both the people within infection slow and infection fast can clear their infection to our uninfected cleared box, where we assume that there's no viable bacteria to reactivate without reinfection. We've also incorporated subclinical TB in addition to clinical TB. This is to align with recent prevalence surveys, which have estimated both subclinical and clinical TB prevalence in countries. Both subclinical and clinical TB can naturally cure to our recovered box, and we've incorporated it on treatment with treatment initiation, failure, and loss and completion. Particularly, these two boxes were novel for including in a tuberculosis natural history vaccine model. And so we wanted to look at the interaction between, or we are wondering about the interaction between these two boxes with the estimates. And so Danny Scarponi et al. Actually have looked at whether or not including this uninfected cleared box will have any impact on the vaccine impact estimates, but that's not the main focus of here, where we're just looking at using this model structure to look at the impact in LMICs. For certain countries, we did incorporate an additional HIV ART model structure to account for the increases in progression mortality for those who are diagnosed with HIV. And so we do have a higher risk of progression to TB disease and increased mortality for those people living with HIV who are not on ART and on ART, although lower than people not on ART. And so in terms of our model calibration, we had a number of country-specific targets as well as global targets. So we looked at the 2019 TB incidence and notification rates from the WHO. So those for children, adults, and all ages, as well as the mortality rate for all ages. We had 2 global targets. So basically we assumed that they were the same value for all countries considered, which was the proportion of subclinical TB of all active TB. So proportion of subclinical out of subclinical plus clinical, as well as the risk ratio of active TB in a high access to care group relative to low access to care. So essentially in our model, we divided the bottom 2 quintiles into a low access to care and the top 3 quintiles, or 60% of the population within each country, into a high access to care, assuming that those in the high access to care would have a lower risk of progressing to disease, a higher risk of, or a higher rate of treatment initiation than those in low access to care. For countries incorporating the HIV structure, we incorporated a structure for countries if the HIV prevalence in the country was greater than 1%, and if at least 15% of the total TB cases were in people living with HIV. And so we had 4 additional calibration targets that were specific for those countries where we incorporated this structure, and they included the HIV prevalence, the ART prevalence, and the TB incidence and mortality rates in people living with HIV. And so basically all of these, we had 13 calibration targets for HIV countries and 9 calibration targets for non-HIV countries. Looking a bit more detail about the calibration, so there were 20 countries out of the original list of 135 that we excluded initially due to the fact that they were missing key calibration data. And so we had 115 countries that were left to attempt calibration. And so to calibrate our model, we used history matching with emulation using the HMER package to independently calibrate each of the countries to the targets. And so we ran this process until each country had at least 1,000 parameter sets that fit all of the targets. And then we used these parameter sets to project a status quo baseline epidemiology to 2050 for each country. So this was assuming that the current quality and coverage of care remains constant after 2020. And so once we had our baseline epidemiology with no new vaccine, we compared to scenarios where we did introduce a new vaccine. And I'll discuss the types of new vaccines we introduced in a second. But first, just to mention what we calculated. So we looked at calculating incidence and mortality rate reductions for those vaccine scenarios compared to the no new vaccine baseline in 2050. And then also cumulative cases, treatments, and deaths averted between vaccine introduction and 2050 compared to the no new vaccine baseline. And then we looked at grouping the results from the countries by WHO region, by World Bank income group, and for those countries where the WHO has indicated there's a high TB burden compared to the rest of the countries where it wasn't indicated. So the vaccines that we introduced. We informed our vaccines based on the WHO preferred product characteristics for new tuberculosis vaccines, where they mention introducing a new adolescent adult vaccine and separately a new infant vaccine. So the adolescent adult vaccine is assumed to work in everyone, both pre and post infection with MTB, and is going to work by preventing disease. For our base case scenario, we looked at a vaccine efficacy of 50% for preventing disease and 10 years duration of protection. But then we looked at a sensitivity analysis where we have 75% vaccine efficacy or lifelong duration of protection. For the infant vaccine, we looked at a vaccine which would be efficacious if individuals were uninfected with MTB at the time of vaccination, and it would also prevent disease with 80% efficacy and 10 years duration of protection with a sensitivity analysis of lifelong duration of protection. And one of the key things that we looked at in this work was looking at the different vaccine delivery scenarios. So we really wanted to be able to model some more realistic vaccine delivery scenarios as opposed to instantaneous delivery and scale up within 1 year. So just up on the top right, we can see that there's the vaccine coverage at 5 years, broken into the different age groups that we targeted and broken into low, medium, and high coverage values. So for the most part, we will look at the medium values where we assumed 85% coverage for neonates, 80% coverage for 9-year-olds, and 70% coverage for ages 10 plus. And starting with our base case scenario. So one of the novelties was we looked at initially calculating country-specific introduction years, where we incorporated a range of factors that could influence the likelihood of different countries introducing. And so this is what we can see in the figure here, right in the middle, essentially broken into countries that would be self-procuring versus those that would procure with support from Gavi, and calculated the likely introduction date between 2028 and 2047 of a novel tuberculosis vaccine. And so we can see that that increasing over time. We then also introduced scale up to coverage over 5 years. So once the country introduced the vaccine, they would not reach the total vaccine coverage until 5 years. For this scenario, for the infant vaccine, we looked at routine neonatal vaccination. And for the scenario for the adolescent adult vaccine, we assumed a routine delivery to 9-year-olds and 1 campaign for everyone aged 10 plus. We then wanted to compare this with a more optimistic scenario to basically see what is our consequence of delaying introduction to country-specific years and delaying scale up to coverage over 5 years. And so for this scenario, the accelerated scale up, we looked at introducing the vaccine in 2025 for all countries, and they would instantly scale up to the target coverage. Similarly, we looked at routine neonatal for the infant vaccine and routine for 9-year-olds and 1 campaign for ages 10 plus for the adolescent adult vaccine. But then again, to provide, I guess, a lower bound or a more pessimistic view, we looked at a routine only scenario where, again, similar to the base case, we had country-specific introduction years and scaled up to vaccine coverage over 5 years. But for this scenario, we were only looking at the routine 9-year-old delivery. We did not include the campaign to ages 10 plus. So this to give a more pessimistic view for the vaccine delivery of the adolescent adult vaccine. All right, so moving on to the results from this study. So 105 out of the 115 countries were successfully calibrated. This included 21 countries where we incorporated the HIV structure. And these countries accounted for 93% of the global TB cases and 94% of the global TB deaths in 2019. So we're really, even though we've had to exclude 30 countries from the original list, we are still accounting for the vast majority of global TB cases and deaths in 2019. And reasons for countries not being able to be calibrated have been evaluated by Scarponi et al. In this publication in Epidemics from this year. Here we're just showing the median tuberculosis incidence rate in the baseline no new vaccine model grouped by WHO region. So basically, we can see that we're seeing a higher incidence rate in the WHO African region and Southeast Asian regions, with a slight decline in burden for all countries. All right, so looking at the TB incidence rate reduction. So here we're looking at the adolescent adult vaccine with 50% efficacy and base case delivery. So essentially the routine for 9-year-olds and the mass campaign for ages 10 plus, with 10 years duration of protection and medium coverage. And in line with previous LMIC modeling, what we found was that there would be an important health impact of introducing a vaccine, about a 25% reduction in cases in 2050. And so on the right, we can see we're comparing the incidence rate reduction for the vaccine compared to the no new vaccine baseline. On the left bar, this is those countries defined as having a high burden compared to those countries which were not included on the list. And we can see that they have relatively similar incidence rate reductions. Comparing that base case adolescent adult vaccine to a base case infant vaccine, so where we assumed 80% efficacy, 10 years protection, medium coverage again, we can see that there is a much greater impact from an adolescent adult vaccine compared to an infant vaccine before 2050. So we're targeting the age group with the largest burden with the adolescent adult vaccine compared to the infant vaccine. And we can see that reflected in the incidence rate reductions that we see comparing the adolescent adult in blue to the infant in red. Looking now at the cumulative numbers averted. So this is the same adolescent adult vaccine that we looked at in the previous slide. We have the cases averted by 2050 on the top, followed by the treatments averted, followed by the deaths averted. So this is summing the number of cases, deaths averted by that specific vaccine scenario compared to the number of cases that would happen in the no new vaccine baseline. And so what we can see looking at the number of cases averted is that there's potential to avert around 44 million cases between 2025 and 2050. And particularly these cases could be averted in the WHO African region and the Southeast Asian region. Similarly, with cumulative treatments averted, there's the potential to avert around 25 million treatments by 2050, which could possibly play a valuable contribution to averting antimicrobial resistance. And again, we can see largest numbers in WHO African and Southeast Asian regions. And lastly, the deaths, there's the potential to avert around 5 million deaths by 2050. What we then wanted to do was to compare this base case delivery to some of our different scale-up speeds. So we had the optimistic accelerated scale-up scenario, and then the pessimistic routine-only scenario. And so on the plots here, we can see the blue, which was our base case as we had previously. And then if we were able to increase scale-up speed and introduce in 2025 in all countries, we could prevent an additional 21 million cases, 14 million treatments, and 3 million deaths. So about 50 to 60% more numbers could be averted with this optimistic accelerated scale-up compared to the base case. But if we were only able to offer this vaccine routinely to adolescents, we would avert 35 million fewer cases, 22 million fewer treatments, and 4 million fewer deaths. So around 80 to 90% fewer. And these are in the gray bars here on the figures. Looking again at some sensitivity, we have the base case in blue again, and then we're looking at the difference between the base case and 75% efficacy vaccines. So firstly to say, so with a 75% efficacy vaccine in purple here, we would be able to prevent 20 million additional cases, 14 million additional treatments, and 2 million additional deaths, around 50% more than the same vaccine with 50% efficacy. And if we were able to extend the duration of protection of the vaccine from 10 years to lifelong, assuming 50% efficacy, we would be able to prevent 26 million additional cases, 13 million additional treatments, and 2.5 million additional deaths. And this is shown in the yellow bars on the graph here. Some quick limitations. So we had, in terms of our vaccine targeting, we had no vaccination of specific populations at high risk, except for those by age, whereas countries may choose to vaccinate vulnerable or high-risk groups first, which would increase impact per vaccination. For vaccine efficacy, we assumed that there was equivalent vaccine efficacy in people living with HIV. However, if this was lower, it could produce impact in those countries with a high HIV-TB co-epidemic. But overall, what we've demonstrated is that new tuberculosis vaccines have an important potential health impact. We've shown again that there was a greater impact of adolescent adult vaccine compared to the infant vaccine. For our base case, adolescent adult pre and post infection TB vaccine, 50% efficacy that was introduced between over 20 years, between 2028 and 2047, we could avert around 44 million cases and 5 million deaths, and reduce pressure on AMR by averting 25 million treatments. But as we saw in the sensitivity, we should prepare to do better. If we were able to scale up more quickly and more similar to the delivery of COVID-19 vaccines, we could avert around 50 to 60% more cases, treatments, and deaths. And so we really need to be able to prepare for more rapid production and implementation now. As well, we showed different vaccine profile characteristics, so higher efficacy and longer duration, we could avert around 50% more cases, treatments, and deaths. And so we really should continue to develop better vaccines, and that should hopefully be motivation. So thank you very much. Thank you to everyone listed here for all of their insight and help. And thank you to all of you for listening to the presentation. And I think now we have left a lot of time for questions. So I look forward to the discussion. And thank you.
Thank you very much, Rebecca. That was really interesting and really great to see. Yeah, so any questions or comments or anything, please do raise a hand. I think that small, few enough of us that we can probably just raise a hand and chat about them. While you're thinking about that, I had one very quick question, which was you showed, for example, 25 million treatments averted. And for me, it sort of would be sort of useful to see how many vaccines were administered in order to avert 25, because I just have no real sort of gauge on that. And do you have, presumably you've got those sort of numbers? I think you've done work on their health economics elsewhere, but I was just interested to hear.
Yes, I mean, so we do, like, those numbers are available. I don't have them, I guess, offhand, unfortunately. But I mean, so that would be assuming that, yes, so I mean, for 25 million treatments averted, 80% of, I guess, the 105 countries vaccinated within the 5 years of the scale-up. So I can
do some quick mental arithmetic.
Yeah.
Okay, no, that's fine. That's fine. I was just wondering. And the other thing that I was sort of interested in is, obviously, it's really interesting what you've done here, because you have applied the same model to a really large number of countries. And obviously you're going to get huge amounts of country variability then, and some of that is in the input or in the way that you set it up. But then I was also wondering if you had looked at anything about country variability. So, for example, countries, if there are characteristics of countries where you might expect to see a higher impact due to vaccine than others, like due to HIV burden or age of the population or age of the population with TB or something, anything like that.
Yeah, so that's a very, very good question. I mean, particularly for this analysis, as we were just kind of hoping to group all the countries together and evaluate the potential health impact. We didn't dig deep into different countries and the different specifics about where the epidemic was coming from. But in future country work, we are looking more specifically at some of those countries, like you said, that have more of a high HIV/TB burden, and with different demographics, different demographic structures as well.
All right, thank you. That's interesting. Good to know. Any questions from other people or discussion points? I think an interesting factor that I know you will not have thought of here, but it's sort of an interesting thing to think about, is that because this is looking at very long timescales, you're not going to be comparing it to sort of the status quo, whatever is happening in the TB program. So what does this look like alongside, better treatment regimens or shorter treatment regimens and other new diagnostic tools and so on coming out?
Yeah, definitely. So that is one thing we did evaluate as another sensitivity analysis that I didn't include in the presentation, but I can definitely go through now quickly if we have time. Essentially, we looked at a kind of an NTB scenario. So essentially, but if we were meeting the NTB targets in 2025, which was a 50% reduction in the incidence rate in 2015. And essentially, so we modeled, we had a scenario where we modeled.
My friend Rebecca's presenting something.
We had the different countries meeting the NTB target of 50%, reduction in their incidence in 2025. And so obviously that with the scale up of new diagnostic tools, new treatments, we were averting more of the burden before we introduced the vaccines. So the vaccines appeared to be less effective because they had less of a burden to act on. And so that was one of the scenarios that we did look at. Although it did show that vaccines were still very effective. If I can just pulling up the results now. And yeah, I think I don't actually really have anything to show other than to say that yes, they would still be very effective, but less so than what we've assumed in our current status quo, where treatments and case detection has not increased.
Thank you. Any questions from other people? I have sort of various thoughts and things, but that's very much me just taking up all the time by myself. I guess one of the things that that occurs to me, and I think this is because we've talked about it elsewhere as well, is vaccine efficacy in different risk groups. If there's different, if you expect it to be as efficacious across sort of a range of people with different risk factors for TB, and if not, what does that mean? Should we be thinking about people who are at high risk? Are there more cost-effective ways to administer vaccines and so on? So for, I don't know, household contacts or people with undernutrition or diabetes, or are there different strategies that we should be taking there? And is that something that you will be thinking about going forward?
Yeah, that's definitely something I'll be thinking about going forward, particularly as like many studies have shown that specifically targeting risk groups, like diabetes with a vaccine would have a positive impact on the epidemic as a whole. And so that is something that would be very interesting to look at, particularly if we find different efficacies between, or if there are different efficacies between risk groups. But I think that is something that's very important to look at and see whether or not it would still be, or what the best strategy to be cost effective and have the highest health impact would be.
And just to ask, as somebody not involved with TB vaccines at all, are those sort of risk factors in TB vaccine trials? Is that part of the risk ratios that people are recording and producing estimates for how that efficacy varies, or is that?
I think that's something that should definitely be in vaccine trials, but I think up till now, a lot of them have been focused on different infection statuses. So whether like IgRA positive or IgRA negative, so comparing between that, as well as I know some of the recent trials have started looking at people living with HIV, particularly in South Africa, which, as we know, has a high co-infection burden. But other risk groups is looking at like diabetes and undernutrition and stuff. I don't believe that they currently take that into account in the vaccine trials.
Yeah. Okay. And then maybe a last thing, just particularly thinking about the cost effectiveness and so on, is drug resistance, which is obviously a lot more costly. So every treatment that you avert, if it's 25 million treatments, that I can visualize roughly what that means in terms of pill burden, in terms of dollar cost and so on. If it's drug resistant TB, that's a much higher pill burden and dollar cost and so on.
Yeah, definitely. And so for the economic analysis for this study, which was done by Alison Portnoy at Harvard, we did take into account drug resistance in just a very simple way of using the proportion of drug resistant cases in each country. And so we did weight the treatments the like diagnostic costs by drug susceptible and drug resistant TB. So those would be accounted for in that sense, but just as a very like simple proportion, we did not include any dynamic modeling of drug resistant TB in this model.
Yeah. Oh, that's interesting though. I hadn't realized that. That's really good to see. Thank you.
Yeah.
Richard, do you want to expand on anything you just said in the chat that trials are really expensive to run, so unlikely to have efficacy estimates for risk groups until phase 4, which makes absolute sense. But
yeah, I think that hopefully that kind of explains itself. I think we would very naturally like those estimates, but the global TB research community is having enough trouble buying, running a trial to get the 120 cases to get an efficacy estimate at all, let alone run it so that we can start looking about, which risk groups it might be more or less efficacious. And realistically, I don't think anybody's going to, well, Kristen might have other views. I noticed she's got a question, but I suspect those randomized trials will never be run. We'll be trying to guesstimate them from phase 4 operational scale up and looking at different groups and seeing whether we can see detections in before and after notification rates or something, which will be very, noisy, messy data. But I think that's maybe when we may get something on that.
I would imagine that depends partly on, having not thought this through, on where you're running the trials. If you're running the trials in India and you're looking at undernutrition, huge portions of the population have undernutrition, and particularly those with TB are a massively increased risk. So, if you're looking at nearly, I guess it depends what proportion of the population, but maybe there are some areas where that might not be the case. But yes, I appreciate it.
But you won't know. So there'll be lots of confounding, won't there? Because you will, what you want is a kind of group with and without, a BMI of certain X, and then see whether it has a difference and to power it so that you get a robust difference between the two groups. Yeah, I suspect you'll never get that. You may get some ecological comparisons between different populations where nutrition status is different, but there are lots of other differences between the various populations. Anyway, I'm sure Kristen's got some views on this, so maybe we should bring her in.
Yes, sorry. Christian, do you have a question or comment?
Yeah, thanks, Ben, and thanks, Rebecca, for such a nice presentation. I actually didn't have a question on this particular point. I wanted to ask about something different, which was the assumptions that you made in the base case modeling scenario about, or rather not the base case without vaccination, but with vaccination, about the medium or the manner in which vaccines would be rolled out. So the split between sort of campaigns and routine immunization. I'm wondering, what was the underlying basis for deciding what that scenario would look like, and also wondering if you kind of explored the potential that would look very different by country, or is that true? Would it look different by country, as far as the sort of the split between kind of implementation and more of a routine vaccination framework versus the implementation of campaigns?
Yeah, thank you very much for that question. Yeah, we did spend a lot of time thinking about the different vaccine delivery age groups and methods. For the 9-year-olds, one of our thought for a routine for 9-year-olds was tying in with HPV, and so being able to reach individuals that way with the co-delivery. And then honestly, for a mass campaign, thinking about COVID, thinking about delivering this vaccine to everyone possible. In terms of, access to the vaccine and the delivery, I mean, we would anticipate it would be different. People were very keen to get COVID vaccine and may not be as keen to get the TB vaccine. But I think our main thoughts were looking at co-delivery with HPV for the 9-year-olds, and then just a mass campaign for those age 10 plus.
Got it. That makes sense. And Actually, another question that's kind of related to that, which is, I guess I'm I like thinking about HPV and SARS-CoV-2 vaccines as that things like coverage and rollout might be comparable to what we would expect for a TB vaccine. I think maybe in some countries, in some ways that's true, but I also see HPV vaccines and SARS-CoV-2 vaccines for different reasons as being very different, like differently perceived by the population as a TB vaccine, and also just sort of differently, it would probably be differently implemented, just in terms of the programs that are involved. And in many countries, SARS-CoV-2 vaccines, for example, were sort of these very vertical like vaccine delivery programs that were sort of outside of the regular routine immunization programs. So I'm wondering how much you thought about like potential different, like significant differences in coverage and rollout for vaccines like HPV and SARS-CoV-2 than a TB vaccine. And I realize you're limited, excuse me, I realize you're limited here in the sense that, you are trying to make as many assumptions you're trying to draw on things that you already know to make assumptions about what these programs will look like in the absence of any real information on what the plans are. But yeah, just wondering if you thought about that.
Yeah, definitely. I mean, I think one of the main things that we were focusing on in this work, in terms of the vaccine delivery, was being able to calculate the different vaccine introduction years. And so we spent a lot of time making sure that we had appropriate different country-specific introduction years for the vaccine introduction. And so I think as we spent a lot of time in that, coming up with sensible introduction years, I think we decided to put more of our assumptions on the coverage and the scale up for countries. So we did assume that it would reach the set 80%, 70% coverage for all countries, which may not be true. Like we may and likely will see different coverage levels between countries. And so that was in this work something that we haven't taken into account, but do plan to take into account in future. In terms of the differences, I definitely agree. I mean, yes, we were just trying to incorporate the available evidence that there is. For routine TB vaccines, I mean, I hope that as we assume this would be something that was routinely delivered like yearly once it was introduced, I would hope that tying on with HPV vaccines would be a sensible thing to do, although I do agree that they're obviously coming from different organizers, so it might be some complications there. And I mean, in what we've modeled here, a one-time campaign would hopefully be something similar to COVID, but again, once we actually look at delivering it, we will probably find something different as well. But thank you.
Yeah, you bet. Thanks for the responses.
Fantastic. Thanks very much, Kirsten. Any other thoughts, comments, questions? All right. In that case, and I'm sure, Rebecca, if anything occurs to anybody in the future, I'm sure you'd be very happy to hear from people. And as I said, we will put the recording online as well if you want to go back and look over some of it and think through it again. In that case, I will close. Just remind you that if you are interested in presenting, please do let us know. I think there's a lot of interested TB modelers out there, and it's really nice to hear what everybody's doing and what interesting questions there are that people are working on out there. Oh, and Sandeep's just commented. Yes, thanks, Sandeep. But I think that's about the undernutrition again. I think that's something really important, which I think, Rebecca, you are thinking about going forward. Yeah, so definitely a very interesting thing. Yeah, so thank you very much again, Rebecca. Really nice to see your work, and thank you all for joining us. And hopefully we will see you probably in I think a month or maybe 2 months. We'll send out a date as soon as we have one.
Yeah, thank you
very nice to see everybody.
Thanks. Cheers.
Bye.